Boa tarde a todos, bem-vindos a mais um seminário da redeSAÚDE. O tema de hoje é a multimorbilidade. Welcome everyone to another seminar, redeSAÚDE seminar, today dedicated to multi-morbidity. We have today two distinguished speakers to introduce you to the topic, Professor Rafael Pereira from Oxford and Dr. Francisca Leite from Hospital de Luz. We will conduct this seminar in English for the scientific discussion, but we will first have a short 10-15 minutes briefing about our network that will be given in Portuguese by the chair of the redeSAÚDE, Mónica Oliveira. This is one of a series of events organized by redeSAÚDE that we have planned for this year, together with our main event, the conference that will take place in the fall. We are very thrilled to have attracted such large audience today. But first I will switch to Portuguese before we go to the debate. Portanto, este é mais um evento da redeSAÚDE, que vai culminar com a nossa conferência anual. Houve uma renovação da coordenação da redeSAÚDE no final do ano, com a ida do professor Rogério Gaspar para a Organização Mundial de Saúde, e o professor Rogério Gaspar foi substituído pela minha colega Mónica Oliveira, que está aqui, e que vai ser coadjuvada nesta nova organização da rede por mim e pela a professora Maria Filomena Carmide, da Faculdade de Nutricidade Humana. A Mónica tem uma carreira, para aqueles que ainda não a conhecem, na redeSAÚDE, dedicada a esta área da economia da saúde. É economista de base, mas está ligada ao Instituto Superior Técnico desde pelo menos há 10 anos que eu conheço no técnico, e tem muito trabalho feito na área da decisão multicritério, etc., especialista em sistemas de saúde. Portanto, tenho a certeza que vai dar um excelente contributo para esta rede. E por isso vou dar-lhe a palavra, peço à Mónica então que faça uma sua apresentação sobre para onde é que estamos a ir agora.
Muito boa tarde, olá a todos, muito bem-vindos a este webinário da redeSAÚDE. É a nossa primeira iniciativa deste ano e aqui o objetivo desta pequena apresentação é mostrar-vos um pouco, muito sumariamente, o que é a redeSAÚDE, como é que nós vemos o que é a rede e o que é que gostaríamos de fazer em colaboração com toda a comunidade, seja interna da Universidade de Lisboa, seja externa. Estou aqui a falar como coordenadora, sendo que, como o professor Mário Silva disse, somos uma equipa multidisciplinar que, com todo o gozo, estamos agora a suceder ao professor Rogério Gaspar e a tentar iniciar uma nova fase que é normal neste tipo de atividades. O que é que eu vos posso dizer? A Universidade de Lisboa, como sabem, é uma universidade grande em número de alunos, com uma grande diversidade de universidades, e então organizou um conjunto de redes que façam algo que vai para além do conjunto de escolas. Por isso, a nossa missão é, em primeiro, motivar toda a nossa comunidade, docentes, investigadores, alunos, para promovermos uma resposta ao que são os desafios do setor da saúde, contribuindo para a inovação, novos produtos, novos serviços e, acima de tudo, para melhor saúde no nosso país e também, idealmente, no mundo. A nossa visão é de que a saúde é algo que é um conceito complexo, e então, pegando aqui num instrumento muito interessante sobre o futuro da saúde e dos cuidados continuados, quando olhamos para o futuro, o que é que nós sabemos? Que não podemos falar no futuro sem falar nas tecnologias, na saúde, nos sistemas de saúde. Se pegarmos na inteligência artificial, que vai ser o tema de hoje, temos que falar da geopolítica, da equidade, e se falarmos da multimorbilidade, sabemos que temos que falar de dados, de governança, de demografia. Por isso, aqui a mensagem-chave é que nós na rede temos o nosso ponto de partida em toda esta diversidade, o que significa que a rede o que pretende fazer é colocar todas as nossas escolas, somos 18 escolas que vão das ciências tradicionais às ciências sociais, humanas, temos as engenharias, temos a ciência política, temos as medicinas, as várias medicinas, naturalmente, psicologia, temos um grande número de escolas, temos um grande número de cursos e a questão que queremos é como é que nós podemos ter atividade para o meio, para adicionar valor e para responder ao que são os desafios. Naturalmente, quando falamos da nossa comunidade, nós temos um ecossistema em que tem 10 mil investigadores no perímetro da Universidade de Lisboa e o que nós queremos é ser mobilizadores como rede para todos colaborarmos e para trabalharmos para os devidos fins. Por isso, 3 objetivos-chave que temos. Um é olhando para o que são os desafios da Comissão Europeia, do governo português, os desafios sociais, é dar resposta a esses desafios que muitas vezes necessitam de massa crítica. Queremos também motivar a interdisciplinaridade. Este seminário vai ser um ponto central para mostrar como não é com uma área fechada que nós damos resposta ao problema da multimorbilidade que afeta uma grande percentagem da população. E também sabemos que nós temos alunos são a parte-chave da universidade e o que nós pretendemos é juntar alunos e inspirar os alunos, os investigadores a trabalharem com a sociedade nas múltiplas vertentes. Por curiosidade, como é que nós estamos organizados como rede? Tem a ver com o nosso ADN, não é? Podíamos organizar a rede de diferentes formas, mas estamos organizados temos 3 grupos de pessoas de várias escolas a trabalhar no eixo investigação e desenvolvimento, no eixo inovação e transferência de conhecimento e no eixo de sistemas de saúde e transição digital. Este webinário foi organizado pelo grupo de sistemas de saúde e transição digital, agradecendo à líder, à professora Maria Helena Monteiro, da nossa Escola de Ciência Política da Universidade de Lisboa. Depois estamos a organizar-nos com grupos transversais, sendo apostas estratégicas na Universidade de Lisboa a medicina de precisão e o envelhecimento, e naturalmente em áreas onde nós consideramos também prioritárias organizar-nos, temos grupos para organizar atividade direcionada para a melhoria dos cuidados e da saúde em oncologia, nas doenças neurodegenerativas, nas doenças infectocontagiosas e nas de metabolismo cardiovasculares. Também para perceberem um pouco algumas das atividades-chave em que estão na nossa incumbência, existe o European Institute of Technology, financiado a nível europeu, que junta um consórcio de universidades, empresas, instituições de saúde para ligar o ensino, a inovação, a investigação à criação de emprego e de empresas. Por isso nós, como rede, também estamos a organizar ou tentamos coordenar esta atividade e, claro, aqui muitas das pessoas que estão aqui neste webinário trabalham em empresas, lancem-nos desafios que nós queremos ter o máximo de interação com a sociedade e ir a jogo em boas candidaturas para adicionar valor. Também outra das atividades que temos organizado tem a ver com o consórcio Lisbon Living Plus. Somos uma das entidades-chave, entre muitas, em que nos estamos a organizar de forma a termos uma arquitetura colaborativa que faz com que seja muito mais fácil nós unirmos para desenvolver projetos de vários tipos e, naturalmente, organizamos um conjunto de eventos que pretendem motivar, inspirar toda a comunidade. Não me vou alongar mais, àqueles que estão presentes da Universidade de Lisboa, teremos na próxima semana uma sessão para aprendermos um pouco do que é que está a mudar no Horizonte Europa e para discutir o contexto. Isto é uma sessão interna da Universidade de Lisboa, mas as outras universidades estão também a organizar este tipo de eventos e há eventos para a indústria também, em colaboração com a SAÚDE. Queremos também anunciar que estamos a construir um evento conjunto, onde vamos organizar um evento acelerador para ver se conseguimos promover novas ideias para chegar ao mercado, e nesse evento conjunto planeado para novembro de 2021, vamos acoplar em 2 dias o resultado do evento acelerador, mais uma conferência aberta à comunidade, uma conferência de saúde pública, e também juntar os nossos investigadores da Universidade de Lisboa, na 5ª Conferência Anual da redeSAÚDE, e tendo já descrito um pouco o que nós queremos fazer e dos eventos que temos planeados, passo agora a palavra aos restantes membros, querendo aqui agradecer muito a presença do professor Rafael Pereira e também da doutora Francisca Leite, que aqui nos deixam elevadíssimas expectativas sobre o que é core na rede, de não só misturar tecnologias com o que são os objetivos do sistema de saúde, e a perspectiva seja mais académica, seja de quem está no mundo real, num hospital que pretende inovar, mas que tem aqueles problemas reais de todos os dias, e que naturalmente não quis centrar a minha apresentação no que é o Covid, mas nos tempos atuais, que os desafios ainda são mais prementes do que o que costuma ser usual. Muito obrigada pela vossa participação, e vamos agora ao que é a parte importante deste webinário. Muito obrigada.
Obrigado, Mónica, pela atualização. So we're going back to English. So welcome everyone now to the seminar on AI and data science for the treatment of multi-morbidities, also known as multiple long-term conditions, I believe, in the UK. So we are dedicating this seminar to recent advances in data science and on multi-morbidity, and also to the application of AI methods to the clinical practice and long-term care for addressing groups of chronic diseases. This is basically the topic. We felt that we had to bring this topic because with the aging of population, especially in Portugal, we are confronted with the need to better understand multi-morbidity, clinical pathways, together with environmental, behavioral, and psychological factors in the disease. So we are very, very happy to realize that we had so many participants, 400 registered, 211 attending this at this moment, which appears to confirm the timeliness in bringing together this team for the discussion today. So we have 2 distinguished speakers to introduce you to the topic: Professor Rafael Pereira from Oxford and Dr. Francisca Luz from Hospital da Luz, which I will introduce to you later. So Rafael Pereira is the director of the statistics group in the Nuffield Department of Primary Care Health Sciences at Oxford and United Kingdom, which I believe he joined 20 years ago. His main research focus has long been on the monitoring for the management of long-term conditions, and he's on various national and international panels on healthcare policy at different levels. So he is a full board member of the National Health Institute Research and Innovation, is that correct? Health Technology Assessment Commission, and Director of Research Methodologies in the Center for Evidence-Based Medicine at Oxford. I have known him through the work that is published on the research, UK Research and Innovation Department of the Medical Research Center in the UK, where they have been producing very interesting work. In particular, I got to know him through the inspiring roadmap document on multiple long-term conditions from 2018, which I believe called Multi-morbidity, a priority for global health research. And I believe this has led to a program that is now going on in UK, where they have identified the research on multi-morbidity as an urgent priority for the UK and globally. And there is, I believe, one of the 7 health-focused teams on the MRC's delivery plan. So very hot topic, and very, very glad to have Dr. Rafael Pereira accepting to be with us to discuss the theme. So he has a presentation that he prepared for us. So I would give him the floor now. And thank you again.
Thank you, Mario. Thank you, Monica. I think this theme, this subject is very appropriate for collaboration, for a network, because we will require approaches and multiple disciplines to try to explore the ways that we might be able to approach and hopefully eventually solve these issues that raise and come with multimorbidity. So I'm going to start sharing my screen, and hopefully you'll be able to see my presentation. Is that correct? I assume that you can see my presentation. Okay. If there's any issues, I'm very happy to hear. Obviously through the chat, I'll try to answer them after the talk, and obviously I'll stay for question and answers. As Mario kindly mentioned, I'm a statistician. I've been based in the Department of Primary Care since 2002, so for nearly 20 years. And I've been working for the last 15 years or so on trying to understand how we manage long-term conditions, particularly from the perspective of using biomarkers to support clinical decision-making. And the classic examples would be things like, for example, using systolic blood pressure to try to manage people with hypertension, or using HbA1c for those of you that have some clinical background, as some level of glucose in your blood to manage people with hypertension. And I've been based in a department of primary care, or a department based around understanding how family practitioners provide health support to individuals. And therefore, in a way, my perspective is very much from that side, trying to understand how we support general practitioners and generalists in a way to deliver the healthcare we need. So this is the outline of what I'm going to be talking to you today. And let me just start my counter. I'll tell you a definition of what multimorbidity is and how that's actually changing a little bit. So I'll present a couple of definitions that are somewhat related, but not exactly consistent. And then how in the UK, we're now moving towards thinking on, instead of just broadly multimorbidity, trying to narrow it down to multiple long-term conditions, which is a very specific subject. I'll tell you why I think we got where we are. And this is probably going to be something that you are already aware of, but I'll just emphasize the reasons for why we are where we are. I'll talk a bit of why we think this is problematic, the impact of multimorbidity on the health systems, and we are now in a situation where the health systems are not fit for managing these particular issues, and why, therefore, we need a different approach. And I'll suggest what approach I am at the moment chasing, trying to understand if this might help us to manage these individuals with multiple conditions. And finally, some key challenges identified as part of my work, but also importantly, part of the work that the different funding bodies in the UK have been producing over the last couple of months. I'm going to touch on information that was part of workshops between the engineering funding bodies and also the national health funding bodies. So first of all, defining multimorbidity. There are, as I was saying, plenty definitions, and these I'm just going to show you a couple, and there are some consistencies, but there are also some differences. So this is a work from the Academy of Medical Sciences, where they say multimorbidity is the coexistence of two or more chronic conditions. Each of one is either a physical, non-communicable disease of long duration, such as cardiovascular disease or cancer. Cancer is considered a chronic disease of long duration. A mental health condition of long duration, such as a mood disorder or dementia, or, importantly, could also be an infectious disease of long duration, such as HIV or hepatitis C. So as you can see, the focus is on multiple chronic conditions, at least two. So that's where we start off. And in a way, this is incredibly broad because there are such a number of chronic conditions potentially available that having two, it means that a vast majority of individuals will be in. A slightly different definition of multimorbidity by Esta et al., which is a little bit, actually, I would suggest much broader, than the one from the Academy of Medical Sciences, is to say that multimorbidity is defined as any combination of chronic disease with at least one other disease, could be acute or chronic, or biopsychosocial factor associated or not, or somatic risk factor. What this means basically is any interaction, like for example, a chronic disease that interacts with poverty or interacts with stress or addiction, will then highlight this as having an individual having multimorbidity. And what's critical for the Esta's definition is that it modifies the potential health outcomes of the individuals. And that's why they found that it's very important to include biopsychosocial factors. We know that poverty, stress, addiction, low socioeconomic levels are increased levels of disability and decreased quality of life and potential frailty. So that's why the Esta thinks that that's an important thing that we need to include. But the downside of that is that obviously makes the problem even much more complex and more difficult to manage. So where are we now with these definitions? Of late, and this, as I was saying before, picking up on what is the latest thinking in the UK, the National Institute for Health Research, is to, instead of talking about multimorbidity in general, there's been a redefinition, a refocusing on focusing mainly on multiple long-term conditions. And this is their definition, two or more. And there's been also moved towards what we call complex multimorbidity, when you think of four or more multiple long-term conditions. But in this case, it's two or more long-term non-communicable diseases, such as mental or physical health conditions, or it could also be infectious diseases with long duration. And the examples are the obvious ones: diabetes, dementia, depression, etc. And added on to that, complex care needs. And there would be the examples that they use are people with cerebral palsy or motor problems, visual impairment, and learning difficulties. So we an example of an individual with complex care needs, and then the interaction with two or more long-term conditions. So one or the other, we'll be talking already about individuals having multiple long-term conditions. And this already creates challenges of how we're going to start addressing and accumulating evidence for the study of individuals that have these particular health needs. And just to give you as an example, NICE is probably very well regarded internationally. In the UK, it stands for the National Institute for Health and Care Excellence, and it provides guidance to support and provide better and consistent care across the UK. That's their basic remit. And as you can see in this slide, for a condition such as stroke, we have very clear elements, very well defined pathways that include things like treatment, rehabilitation, and importantly, prevention. So how can we prevent stroke? When we move into what NICE is able to say about multimorbidity, the pathway, first of all, as you can see, is much simpler, highlighting that it's a very complex issue and there's a general lack of evidence available in this case. Importantly, there's almost nothing, it's actually nothing about prevention or rehabilitation. Most of it is about supporting patients or helping individuals to manage their experience. And notice the inclusion of terms like frailty, focusing mainly on individuals that are towards the end of their healthy life. So multimorbidity in the eyes of NICE, or how we've been able to accumulate evidence for, is seen as a problem towards the latter part of the life, for which there's more like a palliative approach rather than a prevention or treatment. And this is critical. And that's why I want to emphasize that the approach that I'm suggesting, in a way, tries to target this particular gap that I see in this space. Now, how did we get here? Again, this is probably something that the great majority of you have seen before or have thought about it before, but in a way, multimorbidity is actually a story of success. And that is because 120 years ago, most of the people that died were because of infectious diseases. Maybe COVID-19 now has changed the scenario for the last few months, but certainly in relation to 2010, for example, even 2019, there's been a very clear difference between what happened 100 years ago and now. Instead of having people dying from infectious diseases in 2010, the most common causes of mortality were things like cancer, heart disease, and cerebrovascular disease. And if we were to look at the actual impact on mortality, I just want to highlight in this graph the differences between death in 1900 and death in 2010. Mortality has declined about 54%. And the causes of death, the ones in blue, which were acute conditions, have pretty much disappeared. They're almost gone completely. And instead, we have chronic conditions, the usual ones. Cancer, heart disease are the biggest one, diabetes, and other non-communicable diseases. And this has happened relatively quickly, certainly in the last 60 years, since the end of certainly since a few decades after the end of the Second World War, we see a very rapid increase in life expectancy. I have this graph showing the life expectancy and how the trajectory of change has happened since 1960 in the EU and in Portugal. And the UK is very similar. Unfortunately, I couldn't get data from the UK. As you know, we've left the EU, which means that the data were not available in this particular website. But what I want to highlight here is this trajectory of increase in life expectancy over 60 years. In some cases, there's been a rapid increase and then a slightly less tapering of the increase in life expectancy. But in the case of Portugal, again, there's been an increase of around 20 years of an increase in life expectancy. Most of them, in the initial part of it, there was a rapid acceleration and then a plateauing. But importantly, although now life expectancy is around, in most European countries, 80 years, a little bit more for women, the healthy life expectancy, and I'll expand a little bit more of this in my next slides, is significantly lower. It's about 64 years, which means that about 15 of our last years of life are likely to be spent unhealthily. And this is obviously critical in our understanding and our telling of why multimorbidity is important and how and why it's affecting most European countries. If we look specifically in the UK, so in the UK, we have data from around, again, the middle of the last decade that just passed, 2016, and showing very similar to the rest of Europe that the life expectancy in men and women would be around 80 years. And although there's been similar gains over the last 35-year period, there's been a slightly closing of the gap in terms of males gaining a little bit more of life expectancy compared to women. So that gap that used to exist in 1980 between women and men, with women living significantly longer or having a longer life expectancy compared to men, has narrowed significantly. But, and this is the graph that I wanted to get to, the increase in healthy life expectancy hasn't been proportionally as big as the increase in life expectancy when we live in poor health. So we spend, over the last 15 years, there's been an increase of around 2.5 years of life expectancy, 1.5 of those in good health, 1 of those years in poor health. But the ratio of total time that we spend, the increase in a way of total time that we now spend in poor or bad health is actually not adequate. So we spend slightly more of our life expectancy in poor health. Previously, 15 years ago, it's around 20%. Now it's about 23%. So positive side is, yes, we're living longer. Negative side is about under a quarter of our life is spent in poor health. And this is roughly the same for both men and women. So I just want to highlight that the increase that have existed and the increase in life expectancy in relatively poor health is exactly the same in both men and women. So for those of us that are in the second part of our lives, this clearly makes for not particularly nice reading. We're going to live longer, but healthily around age 65. After that, we're probably going to end up dealing with a significant number of conditions. So we need to start thinking about that. And when we think about the conditions, not only living with a condition has started to happen, but also the number of conditions that people have has increased over time. And this is a study that was carried out in Oxford by Jenny Tran, where they looked at individuals that had survived a heart attack, and after survival, they worked out the number of conditions that they had at the point of the attack. And this happened, so they created a series of different cohorts, different groups in 2000 all the way to 2014 to try to understand the characteristics of those individuals. And what we see here, what I want to highlight, is that the number of conditions in 2000 was roughly around, the majority of people had one or two, and very many of them would have zero conditions. Around 15% of those would have zero conditions. But by 2014, over 40% had 5 or more. So there's been a big hit in the number of people or a number of conditions that people with this particular characteristic, which is surviving a heart attack, will have. And if we look at what are these conditions, probably you will find the usual suspects: hypertension, you can count it as a condition or as a risk factor. You have depression, arthritis, asthma, etc., etc. So the usual suspects are ever present. We are just having them more and more. And you would say, well, maybe this is just because we're getting older, and therefore the people that get a heart attack, we might be getting better, and then they get a heart attack much later. And that's what we're seeing all these individuals having multiple conditions instead of just one or two. Well, what's happening, it's not, when we analyze these data, it's not exactly true. We actually have levels of multimorbidity very early in the process. So as we can see, this is separated by different age groups, and even by the age of 40, you would expect in the 40 to 49 age group, you would expect around more than 50% of individuals having multimorbidity, that is more than 2 conditions. Why is this happening? Well, it's not only aging, but also we're getting better at identifying and diagnosing. So it's a combination of all these issues. And maybe we're getting worse in terms of health, overall health in our population. That is another argument. It's difficult to untangle all three of these different aspects. And because of that, actually working out the prevalence for all these reasons I'm telling you, in terms of we don't necessarily know if we are getting better at diagnosis, if we actually have just a good handle of the definition of multimorbidity. Trying to map out the prevalence of multimorbidity is really challenging. So here we have a series of studies that are represented, each one with different colors or dots, depending if they provided only information from a specific group, and mapping up the level of multimorbidity across different ages to try to understand, as I was saying, the prevalence of multimorbidity in different populations. And as you can see, there is substantial variation. Some groups showing multimorbidity in the early stages. So for example, the REDE study, the study by Barnett, 10% of those age 20 had multimorbidity, 40% of those age 60, and 80% of those age 90. While in the GOLD study, have just presenting a much higher level of multimorbidity, the study about nascence, it showed 35% age 20 having multimorbidity and 80% of those age 50. And again, they might be partly due to difference in population. The study in REDE was carried out in Scotland. The study in GOLD was carried out in the US, but probably it's more related to our definition of multimorbidity and also how the diagnosis occurs in these different groups. So it is a challenging, even at that stage of defining or deciding what is it that we're studying. But even then, I want to explain why we think, why it has become such a problem, to the point that there's multiple people looking at this. The WHO has termed the idea that the next decade should be all about healthy living as a response to what's happening in this particular context. So I'm just going to show you a series of slides showing the level of resource utilization in this group. and potentially how it's associated again to multiple conditions, to multimorbidity. Here we have the impact, the number of admissions that occur after attending the hospital for an accident and emergencies between 2007 to 2019. And the main thing I want to highlight is this pretty much linear increase over that time period. So admissions are just increasing almost linearly. Critically for the UK, I'm not sure what the state is in Portugal, but critically in the UK, that has coincided with a reduction in the level of resources, specifically the reduction in the number of beds in hospitals. And as this reduction happens, this creates a perfect storm. Some people will argue that that's one of the reasons why the UK has been so badly hit by issues surrounding COVID-19. I won't go into any further details regarding that, but it just highlights admissions increasing constantly. If we were to look at the age profile of these individuals that are admitted, you will see that the majority of them are in the 65 plus age. So there is this group of over 65s that are responsible for the majority of the admissions. How does that reflect overall in regards to the people that attend A&E? Well, in this graph, we see that most of the attendance to A&E happen to fall, or the modes of the distribution happen to be the young children and then young adults. Those are the ones that most typically attend A&E, but they don't end up being really admitted. Most of them will go home after a few hours. How many hours? Well, we have this threshold that defines a 4-hour waiting target. They will be seen quickly and then sent home. Once we get to, again, we're close to 50 years and over, we can see that this waiting target just increases. So the chances of breaching that target increases exponentially. Very often, we'll get all these individuals, again, the elderly, not being able to be managed or seen quickly within the A&E department. And that reflects obviously in resource utilization. So if we want to look at this group in particular, the length of stay is strongly associated with comorbidities. The longer, so the more comorbidities they have, the highest level of conditions they have, the longer they're likely to stay, and also associated with readmissions. So it has a huge implication on resource utilization. And this is just from the perspective of accident and emergencies. I'll tell you a little bit more about just general management of chronic care. And the way it's been managed so far is roughly within the system. So we have a focus on diagnosis and initial management in the hands of specialists. We get individuals that are consultants in diabetes, cardiovascular disease, respiratory disease, etc., identifying, managing the individual for that particular condition and sending them back, once they're stable, sending them back to the primary care practitioners for them to be managed. And there is a huge disconnect between what happens here and what happens here. So by the time the patient or the individual gets back to their families, being managed, they might have potentially accumulating a series of conditions, such as, let me just give you an example. For example, you would have a 42-year-old woman diagnosed as diabetic by her doctor. She was asthmatic since she was 12 years old, carries an inhaler so that she uses every now and again. The labeling of being diabetic has made her feel anxious and depressed, and she doesn't know how she's going to manage. So in that, you have different psychosocial and physical conditions that are all mixed together in order that impact on the individual well-being and how she's going to be managed. And even sort of more complex case, a man that at 45 was found to have an enlarged prostate, then to deal with that anxiety that brings, he started drinking whiskey. Later, he finds out that has impacted on his blood pressure, which once it's measured is 145 millimeters of mercury. At 51, he's then found to be diabetic, and 2 years later, he suffers a nerve damage on both his fingers and toes. At 69, he's diagnosed with Parkinson, and finally at 72 with heart disease. He's still alive, but obviously his case is so complex that an individual, a consultant, will not be able to manage all these different characteristics. And that is the reality not as complex as that, but for large amounts of individuals. As an example of, again, expenditure of long-term care outside accidents and emergency in hospital, in the UK, the total long-term care expenditure in 2017 was close to 50 billion, which is around 2% of our GDP. And 2/3 of that, this is probably a shocking, but maybe not for everyone, statistic, 2/3 of that is financed by the government and 30% of that by people directly paying for services and medication. So a significant proportion of the expenditure and the management of long-term conditions, multi-morbidity in general, is done by the individual. And just to put it in context, according to the CDC in the US, 90% of the 3.8 trillion of annual health expenditure are for people with chronic and mental health conditions. So this is a big, big problem, just in terms of resource utilization and also for the individuals. I'll touch more about the individuals in a minute. So we need a different approach. How am I proposing that we might be able to deal with this? How can we target a different different approach, a different perspective? And I like this slide. It shows a certain utopia with clean air, clean water, open space, and healthy living. That's where we would like all to live. But let's take small steps. Obviously, as I was saying, the United Nations thinks of this as a critical issue and has declared in 2021 to 2030 the decade of healthy aging as an opportunity to bring everyone together to actually provide and support the sort of healthy aging and healthy living. Obviously, we want a healthy life and we want to age healthily. But so far, the way we are told that we will achieve this is by relatively, how would I say, good-natured advice. So we hear sort of 10 things that I've highlighted. Watch what you eat and drink. Okay, try not to get obese. Look after your teeth. Stay active. Make the most of your doctor. So make sure that you get good clinical advice. Get vitamins. Debatable, depending on which vitamins. Take care of your feet. I think that's actually very important. Sometimes not enhanced enough. Sort out your sleep. Make sure you get enough sleep. Take tests. So make sure that you know where you are, particularly cognitive. Stay in touch with individuals. It's important to keep your social connection and give up smoking. So those are very valid sort of pieces of advice, but I think we still could do better than that. And for that, I believe that we could actually use information, obviously being a statistician, that's where I will come from, use information to provide individuals with tools to support that healthy aging. I think even now, we already collect significant information regarding the state of health of an individual, and that we can do better with the data that we have and integrate it in such a way that would support the delivery of better, personalized, hopefully, healthcare. And that's where I'm going. What am I thinking? How do we get there? Well, we start most of the process with diagnosis, and we have different ways of diagnosing. There are different modalities. We have imaging for things like cancer. We have clinical diagnosis that are usually based around a combination of different types of symptoms. And then importantly, from my argument, we have diagnosis based on biomarkers. And the significant number of the conditions that we talked about, multi-morbidity, are based around understanding that people have a certain level in their biomarkers that is beyond what is deemed as normal. We think of them as being in the extreme of normal. So the extreme blood pressure beyond 140 systolic blood pressure, SBP, we say that individual has hypertension. Beyond a certain level of HbA1c, glycated hemoglobin in diabetes, we say that person has diabetes. And we use that information to manage these individuals. Again, for asthma, it could be decline in FEV1 or the level of how well your lung is supported. And we could use this approach across multiple conditions. If we have, like in the case of a man, an individual with heart failure, diabetes, enlarged prostate, etc., all of these things have been used not in every case, but in many cases, we will be using biomarkers to manage these individuals. And as part of the management, we're already thinking about sort of the temporal dynamic element of this, how these values for these different biomarkers have been changing over time. If there's specific trajectories, if there is a process that is actually stable, or is a process that is unstable and changing for the worse or changing for the better, we already use that. But I think this is the important challenge. It hasn't been put together. We still manage each one of these trajectories individually. And what I think we need is an integrated system that will put together all these things in one place. We already have something similar to this. This is just a screenshot of what happens in an intensive care unit, which is monitoring all the vital signs for individual. Why cannot we do this for biomarkers in chronic conditions? And I'm going to show you in the next few slides some of the work that we've been doing. This is work from a PhD student of mine, Mei-Sun Chan. She has submitted her dissertation and should be defending it in the next few weeks. It's data or analysis that have been collected from something called the UK Biobank. The UK Biobank is a fairly large cohort of individuals, 500,000, where multiple biological factors were collected, many biomarkers, but also characteristics of the individual, blood tests, and then we will follow up over a period of time. There's several sub-studies on them as well. And importantly, there were individuals that were relatively healthy. So not all of them were healthy, relatively healthy, between the 40 and 70 years of age. And what I want just to highlight in these next few slides is probably something that you already knew, the strong association between age and all the different conditions that we're interested in. So if you can see in this slide, we have for neurological conditions, an increase in incidence as we age. The same thing for respiratory. If we look at other things like atherosclerotic disease, cardiac disease, gut, inflammatory markers, metabolic, musculoskeletal, etc., we have these very relatively strong, well, fairly strong associations. In some, they are less strong than others. That is true. But generally, age can be seen as an important, or is seen already as an important marker of important risk factor. For some conditions like cardiovascular disease, just being old can push you at higher levels of risk that you will already be receiving medications, regardless of what other markers you have available. And the issue is that we know that there's significant variation in aging individuals. We have seen 80-year-old that looks like a 60-year-old. We think that person looks very young, and vice versa. We've seen 50-year-olds that actually look very old. So there are significant variations. Whether that's associated with mortality or not, that's what we would like to know. And in order to create that bridge between the association that we see in different kinds of morbidities or conditions and biomarkers could be bridged through the biomarkers themselves. So here, what we are putting together is the association between different levels of biomarkers and the different ages. And for some biomarkers, it's very straightforward. Here we have two populations. So again, in this UK Biobank group, we separated between those that had a condition at the start of the study that are defined in red, and those that were healthy, had no conditions at the start of the study, and are the ones in blue. And basically plotted or worked out what would be the links or the average values between different biomarkers in these two age groups to see if there were some consistencies or differences, and also the association between age and different levels of the biomarkers. And as you can see, for systolic blood pressure, there appears to be almost a linear association. But for other biomarkers, the association is not as straightforward. So FEV1 is lung function. There's again, probably broadly linear, but actually declining with age, both in the ones in poor health, but also the ones in good health at the start. But for other biomarkers like the systolic blood pressure, the association is not that straightforward at all. And so on for things like BMI. This is a particularly challenging and really interesting and important risk factor. We know that BMI is very strongly associated with multiple or long-term conditions, particularly high levels of obesity. So the fact that that is not particularly well associated with chronological age, that creates a challenge to the type of things that we want to carry out. But other things like, and even probably more challenging, things like LDL, so bad cholesterol, the associations observed are fairly complex. We think that might be strongly associated with some important events in the lifestyle. So what are we suggesting in terms of integration? Well, using all these different biomarkers and combining them together into either one or multiple biological ages. We can think of changing or using even in some cases a chronological age of individual, but more importantly, the different biomarkers. We think that with the biomarkers, we'll be able to work out if a person using their cholesterol, their blood pressure, their lung function, their glucose level in blood, etc., will give us a good measure of where they are in terms of their biological age. Or alternatively, we can think that we can do exactly the same, but for multiple systems. So we can create a long age, cardiac age, that in combination will provide us maybe the overall state of the individual. And we can think of these issues, so these different biological ages, as a way of creating our integrated management care for chronic diseases. And we've done that. So as you can see in these graphs, we calculated or created for each one of these system ages, the equivalent, a cardiac age and a musculoskeletal age. I'm presenting these two for men and for women. And what's being highlighted here in different colors are the tertiles. So we divided our group into 3 categories. Those that showed the youngest cardiac age, for example, the average cardiac age and the oldest cardiac age at baseline, and then follow them up over a period of time and found out if they got an event. In this case, if they were found to have a cardiac event. And yes, this discriminates quite well. It separates very well between the 3 groups, for men and for women. And musculoskeletal age does exactly the same, even more impressively. This is not the case for all ages. I have to admit, this is not the case for all ages. For this, I'm just highlighting the ones that do particularly well. For other ages, it doesn't work as well. But with that, we can come up with a combined measure of the effect of these different biological ages on the total age of an individual. And in this graph, what it's highlighting against those tertiles, so we have the closer you are to the center will be the older groups. So those in the first circle are the ones that the third that were the eldest, then the middle ones, and then finally the youngest. And in this graph, what I'm highlighting is that, for example, for cardiac disease, there's an increase of or a decrease of 7 years. So you are 7 years younger if you are in the youngest group compared to the average, or an increase of 10 years. So you're 10 years older if you're in the older group. So that's on average. And for musculoskeletal conditions, again, there's a 10 years younger if you are in the youngest group compared to a 16 years older if you're in the further away group. And the same thing we could apply also for women. So this is integrating information across all these different biomarkers and then putting them together to represent in such a way what is your health state at a given time point. And we can do exactly the same thing for women. So I think we are at the threshold. We are able nowadays to collect vast amounts of data, very often using things like point-of-care devices. These are 3 that are the most commonly used. For example, measuring blood glucose, measuring blood pressure, and also measuring your FEV1, so the degree of how well your lungs are functioning. We can get this data without it being particularly invasive. We can get data quickly. We have some of the technology. We need to develop it further of how to integrate this information. And we need, the next step obviously is to pass this information to the system so that there's adequate interaction between the health practitioners, between the patients and their data to decide how to use that information appropriately. And it could be, what I'm suggesting it could be used to identify wrong trajectories that could be corrected early in time, rather than waiting too long and then managing multi-morbidity, when in reality that's just way too far. And you will say, well, this is just pie in the sky. This is just, you're just thinking, this is just not possible. But this already exists. This is already happening. In a group of people, those with high levels of resources, they are already managing their biomarkers. They're already working out their heart rate, their blood oxygen levels, their breathing rate. We're using wearables, using information. The rich are able to manage their health, and the poor are managing disease. And this is something that's just increasing inequalities in healthcare. So it is possible. It's already happening, and we need to integrate that information so that it's better and consistent across all the individuals. And for that, we think we need something completely different. And this is a slide that I borrowed from a workshop, a joint workshop between the EPSRC, which is Engineering and Physical Sciences Research Council, and the NIHR, the National Institute of Health Research, understanding that the approach of working on silos, even saying this is an engineering problem or this is a healthcare problem, is no longer feasible. We need to integrate and try to approach it in a joint fashion, understand what the problem is, assessing how we're going to deal with it, understanding what potential solutions are, assessing the system cost and risk, and importantly, I think from the perspective of engineering, adjusting constantly, not thinking that we're going to end up with a solution that will be useful and valid across. It needs to evolve with time, simply because the individuals that are using the system will be evolving, and the system itself will be evolving as well. So again, borrowing from this workshop, these are the health priorities identified by the EPSRC. They will work, or the idea is to work. I'm hopefully going to be involved in this, in next generation digital health systems, supporting engineering, healthier environments where people live and work, for a future that's affordable for healthcare solutions, where the technologies exist to improve healthcare treatments. As I was saying, this is already it's already a reality for many people, not for everyone, and that is the challenge. How we get to that stage where this will be appropriate for everyone, not only for a selected few. And there are a series of challenges that we need to approach and to deal with in order to get there. What are these? Again, I will borrow a little bit from the workshop. I'll present a slide from the workshop, and I'll define my own, the ones that I think are particularly difficult to manage. So in terms of the workshop challenges that were highlighted, high quality care shouldn't be a task for the patient. Very often, as I was showing in my slide, most of the weight of the management of the condition is passed because of the system. I don't think it's an individual thinking or an individual healthcare practitioner thinking that the patient should do all the work, but it's just because of the way the system works. Most of the management, most of the dealing, and even in some cases, the cost is passed to the patient. And this obviously creates even more inequalities. Some people will have either the resources or the mental ability or the inclination to do it well, and others just will not be able to do so. Second key challenge. People with multiple long-term conditions have diverse needs, and these will change with time. Again, reflecting what I was saying about an engineering solution. We cannot expect that individuals will be sorted at a given time point and will be therefore the same or sorted for the rest of their life. The changes of people with multiple long-term conditions change over time. They will be different when they are 30. So the conditions that have been accumulated when people are 30 or 50 or 60 will be completely different. And if we think about prevention, if we think about potentially identifying trajectories earlier in time, then again, the needs of individuals when they're 30, and in order to change those trajectories will be completely different to by the time that if we are unable to stop those trajectories, those conditions already exist. So we need to adjust the system or create a system that will allow us to meet those needs and those modifications in good course. We need to have a cultural shift to get a system that is oriented about patient needs. Again, this is not a problem, or this is not an issue about the individual doctors, but it's the fact that the system is organized in such a way that it's mainly around consultants or mainly around specialists that, because of the nature, deal with a specific condition or a specific problem, and not about sort of the management or the movement of individuals across all the system. And the services need to be coordinated in most cases. And although the UK has great systems in place of collecting data, although there's a relatively good healthcare system, there's very little connection between even information provided in primary care, information in secondary care, the hospital information and general practice information. The amount of data passed from one side to the other is actually still very limited. There's no good integration there. The workforce, and this is going back to this idea of the current system, how it works. The workforce, and that is everyone from GPs to nurses to consultants, needs to rethink how or where the place is in this new setup, how the system might work for people with multimorbidity instead of saying for one individual. And this will require a completely change in attitudes and perspectives. We'll see if that's possible. The care needs to be driven by a better picture of patients' health. And this is very much related to coordination and information, passing information from one side to the other. We need to have needs and preferred outcomes over time. That is still not necessarily all available. I'll show in another slide what people with, or information about what people with multiple long-term conditions say they need. And finally, patients need to be empowered and supported to be active agents in healthcare decisions. This is not that all the burden has to be passed to them, but they have to have agency. They need to be able to make decisions about what is the most important thing for them at a particular time. If I am told you are diabetic and you have to do this, and I'm told you are hypertensive and you have to do this, and I'm told you have chronic heart failure and you have to do this, and some of those things that I've been told to do are contradictory, or I'm unable to do them because of another issue that I have, simply let's say that I have an addiction, or I am too poor to do some of these actions, then that has to be solved first. And there's a complete disconnect regarding that. And in many cases, some individuals, some patients will not, although they want to be empowered, they don't want to be dictated to be responsible in some cases for deciding what should be done. And we prefer to pass all that responsibility to a doctor who they expect will have the right level of information and the right understanding to do that for them. So this is incredibly challenging and obviously requires a whole system approach. The knowledge that is required is not available in a single group. It's not available either by clinicians. They lack understanding of systems. They lack understanding of data. By data scientists, they lack understanding of the clinical aspect. They lack understanding of the systems themselves or the processes and how to modify on that. Engineering as well. Engineers, they lack understanding of some of the aspects. Social scientists, all of those individuals are required to come together and actually start talking to each other and think about how to approach the problem. It is a whole team science approach that is needed. In this ESFC workshop that I'm talking about, the basic questions asked were, what do we want the care system to look like? What are the challenges we need to overcome? What do we need to do to get there? Who needs to be involved, and how can we move the locus of control towards patients? And those are critical issues when we were thinking about the system as a whole. And only then, if we have individuals like the two that I've just mentioned at the center of these systems, we will be able to actually produce something that is useful and is valid for these individuals. I keep talking about these individuals. I will be one of them, or I'm probably one of them in the near future. All of us will have multimorbidity if we live long enough. If we are lucky enough to live long enough, we will have to deal with this issue of multimorbidity. So what do people with multimorbidity, what would I want? So this information, again, collected as part of the NIHR, thinking about what what changes people will need. So in terms of organization of health services for patients rather than systems, the things that we need to change to services that are delivered across the health and social care system. I've mainly talked about the healthcare system. I haven't touched on the social care aspect of it. That is a whole another level of complexity. Thinking about care homes, thinking about individuals that require support for families beyond just health, because they are at risk, children at risk, for example. So what do we expect this to look like? It would require system-wide change, different models of providing care centered around patients with multiple long-term conditions. I think this should go further. This should be a model of providing care centered around preventing individuals getting multiple long-term conditions, and we should be able to move in that direction. And supporting self-management, in enabling people to make decisions about their healthcare, about how to prevent some of the things, highlighting the risks, the personalized risks that they're likely to have, and hopefully providing them with the tools to minimize those risks. And who should be facilitating this? We'll have health professionals in education. This would move away from specialism. So GPs have been thought of as the center of this approach. Also geriatricians, but that might be too late in the process. Geriatricians, because they're generalists as well, they focus mainly on function, which is critically important. And we need that in order to get there, we need to have integrated information, integrated records. Second thing, we need a person-centered care through empowerment. So interaction and partnerships within models of care. We need to have, in order to do that, we need to have strong relationships and partnerships between patients and clinicians. I think there is a gradual movement towards that. In some specialties better than others. In some specialties, there's a very strong partnerships. In the UK, particularly, in fact, all of the research that happens that is funded by the National Institute of Health Research has to go through or be strongly supported by patient in what they call PPI, patient and public involvement. We get these individuals early in the research programs, both as partners and also as evaluators. So they also sit in funding bodies to decide what should be supported and what things should not. And this should be facilitated by technology and effective communication models. We need to provide that level of support. The final theme is mental and emotional well-being and social isolation. What we think we need is enabling bidirectional prevention of mental and physical health problems. This is incredibly challenging in the context that I've described. We have very few biomarkers providing us with a clear understanding of the mental state of individuals. There's been one or two that have been proposed as potential candidates. And we are early stages. Ideally, we will be able to identify strong biomarkers that could be integrated in this part of the system. But if not, we might need to design different approaches that integrates not only information from biomarkers, but maybe information from other sources. An example of this would be there are for people with bipolar disorders, there are certain scores that collect information daily about where the system happens to be. And that might be enough to actually provide us data as to whereabouts in the health state, in this case, mental health state they happen to be. But we need that information. And the way we think this would look like is an integration of physical and mental health services. They're still very much divided. There's work aiming to move towards a better linking between these two. But there's still this duality between what is physical and what is mental. And I think that, well, most people realize that is completely artificial. What happens to the physical side of the body affects the mental side of the body, and what happens to the mental side affects the physical side. We are trying to untangle a little bit if we can identify in some cases what's the causal link, if we can identify specific physical conditions that lead to bad mental outcomes and vice versa. And we're doing some work on using longitudinal data to detect that. And this should be facilitated by communication, which is effective, using things like conversational models, education and training for clinicians in supporting mental health as standard. So in the UK, there's been an understanding that what will require is a shift in the way the NIHR is, on the funding is supported, certainly, but also in the way the research is carried out. So there's been things like a review of the funding process, as I was just mentioning. There's been links between the different funding bodies, understanding that is a problem that requires multiple approaches from different perspectives. There is an interest in engaging with the NIHR community to provide opportunities. So not only linking all these funding bodies, but also telling the community what are the needs, highlighting, not only telling them, but also engaging in conversation to understand what are the needs to deal with this particular approach. Most of what I've just mentioned in terms of the key challenges and also what the community came out from that. There's a need to engage with delivery and implementation to ensure that multiple long-term conditions are recognized as a challenge, and that is research that is worth doing, and that research then is brought into practice. And this is partly because so far, multimorbidity has been in the eye of researchers probably for at least 10 years, if not longer. Most of the research that has happened at the moment has been carried out mainly in defining what multimorbidity is, in explaining and describing multimorbidity, but almost nothing has been then used or is useful to actually change practice. And we need to make that transition, make that gap. We want to, the NIHR want to foster a multidisciplinary workforce through a new generation of researchers. So it's about changing the workforce, re-educating the workforce, and providing them with the right tools to move beyond just specialisms and providing support across all these multiple conditions. We'll support and enable team size, as I was saying. We'll promote a common terminology around multiple long-term conditions. This goes around to, again, to the issue of multiple definitions and the fact that there's multiple ways of dealing with this. That's partly a problem, simply because it reduces the chances of building on research. If we have a common terminology and a common approach, then we can replicate things. We can try or use information that has happened before and collect information much faster. And finally, ensure that research and trials do not unjustifiably exclude patients with multiple long-term conditions. This is really challenging because most of the evidence that's been produced out there is against for single types of conditions. So if I want to do a trial on a medication for, I want to use stroke again because that's the example I used before, then I will exclude everyone with probably diabetes. I will exclude everyone with chronic heart failure. I will exclude everyone, which means that the outcome or the results from the study will actually be only for individuals that do not have multiple long-term conditions. And that creates a very biased level of evidence for which we cannot recover. So in conclusion, and I hope you're still there with me, there are multiple things that I picked up. Multimorbidity is a problem that is caused by the success of modern life. There's been a gradual change. We've been shifting our discussions from description to how to use the information that we have collected from multimorbidity and create new types of research that might allow us to find possible solutions. I think that we can use already available data and integrate it to provide some of these solutions, but it's not available for everything. So data from biomarkers is only available for a limited number of conditions, and importantly, it's not generally well tracked. So I haven't touched on the longitudinal aspect of it. I think that a lot of information will be gained, but not only having a snapshot of the individual, not knowing the level of HbA1c or the level of systolic blood pressure at a given time point, but finding out what happens a month later or a few months later and working out the trajectories of those individuals and knowing or understanding if that change is actually average, normal for most individuals, or is greater or lesser than the majority. And that's where I think that we will find about trajectories of aging, which will be much more important and useful. We think that if we had all this information and we were able to extend it to all conditions, then we probably could find it and identify novel measures and novel approaches to manage this information. And therefore, instead of managing multimorbidity, I hope that we could move towards managing health. As I said in my presentation, these tools already exist, but are in the hands of those with money, and we are just extending the levels of inequality. There are multiple key challenges, and all of them require a team science approach. And in the end, what we want, obviously, as I said, is to give us the better tools for a healthy life, not for a few, but hopefully for all. So just finish with a couple of statements or quotes by individuals. This is a fairly positive approach. My interest is in the future because I'm going to spend the rest of my life there. So that's critically why I think that's why I started studying this approach. I'm hoping that I get old to see the benefits of some of our research, but possibly a more pessimistic approach is by Philip Roth. Old age isn't a battle, old age is a massacre. And I'm hoping that we'll get to a stage that at least we will give people the right tools to fight this massacre. Thank you very much.
Thank you so much. Very, very interesting talk, and quite motivating, I'm sure, for our group. So you really raise the need for multidisciplinarity to address this topic. Thank you so much. I would like to I have a few questions already here, so I would give the floor to one or two. We don't have too much time now because we lost some time with accepting people in. But anyway, I have this question here to user Bits. I don't know if she has already or he has already been unmuted. But the question is, thank you. It was a very interesting presentation. How do you think this psychological age can help healthcare providers make better decisions when diagnosing or managing multiple diseases?
Thank you. The way I envisage, I think about this is by giving health providers more information or more data about what are the critical problems that an individual might face. So if we identify someone as, let's say, their lung function or the trajectory of lung function is decreasing or getting worse faster than everything else, then that might help them identify what are the talk that needs to be had. So saying for a 40-year-old and telling them, look, your lung function, and this has been used in other areas. Your lung function is of a 60-year-old or a 70-year-old, and if you don't stop doing some of these things of smoking, or if you don't stop, then these are the likely consequences. That's been common, and I think for some of these conditions that's quite useful. But putting it in context of everything else, saying, look, you are fine in this and this and these things, but you are particularly bad in this other area. We need to do something about that. That personalizes the issue to the individual rather than just giving them a very broad just interpretation of where they are. And I think that would be particularly useful. On one of the key challenges in a system such as the UK is, at what point would you say it becomes mandatory to ask for the individual, you need to do this, otherwise this is the impact that will have on the health system as a whole. You're actually going to be using much more resources later on, so we need you to actually change that. So there's a whole lot of ethical implications about also the use of these data and the impact that it might have in decision making, not only of the individual but also of those that are dealing with the decisions at health level.
Okay, so I think I've allowed Maria Luisa to talk. I'm sorry, I'm having a hard time managing so many windows and buttons. I have here another question from José Basílio, which is, have you any data on how much time a clinician spends with a patient on average? Clinicians have a lot of administrative work.
Yes, I actually have a slide that we did. Let me see if I can find it very quickly. We have a slide. We did some work using data on general practice of the time spent. Here we go. Let me share my screen. Hopefully you can see that. So this is a work that we carried out regarding the amount of clinical work the GPs, the general practitioners have been doing over time, and looking between 2007 to 2014, and we found that there's been an increase in the number of consultations, the amount of time spent in. So specifically to the question that you were asking, on average, a general practitioner will spend, in 2007-8, used to spend just below 9 minutes, 8:39, and now is more than 9 minutes. So it's very little time if we think about it. This is the average though. So there will be some consultations that happen very quickly and some consultations that are actually take a long period of time. So yes, you are right that there is already a large amount of administrative work that is required by the clinician. This is in itself a challenge. How do we integrate giving them more information? We know that they are pressed for time. How do we integrate giving them potentially more information on the individual? Hopefully telling them what, or hopefully giving them advice as to what are the main things that they should be focused on, instead of being particularly broad. Again, my intention is focusing more on the idea of prevention rather than the management of an acute condition, which is, to be honest, what in most of these cases is what's happening. Most of these encounters in general practice about managing a particular acute issue, either someone coming in with a stomach problem or a problem in the skin, etc., etc.
Yeah, sorry. Thank you for your the reply. Actually, that's I'm of the same opinion, but I think also the clinicians, if they will have more time speaking with the patient, they could give some tips on how to make lifestyle changes. And because they don't have this time, they tend to just focus in handling the disease.
Yeah, I agree. That would require a change in the focus, instead of managing diseases, as I was saying, trying to manage health.
Yeah, thank you.
Thank you.
Okay. So I think we need to move on, otherwise this will get too late. So we have your questions here. You have a lot more questions, but I'll give the floor now to Francisca Leite, so she can give her presentation, and then in the end we can, if we still have some time, we can continue with the discussion of the team. Let me introduce Francisca. So she's currently the head of training, research and innovation at Luz Saúde, and an executive director of Hospital da Luz Learning Health, so affiliated with Hospital da Luz. She was previously a consultant for McKinsey & Company in Lisbon for several years. Before that, she was a PhD in medical engineering and medical physics at MIT Harvard, where she's proud to have conducted research on functional MRI on the awake behaving monkey. This sounds scary, but I mean, that's what she does. She works on biomedical imaging. She now leads the Intelligent Care, which is a project on which we participate together, along with the Carnegie Mellon University, on a project that addresses precisely the topic of multi-morbidity. So that's why we invited her to present this work here. Thank you, Francisca. You can share the screen, I believe.
Okay, I'll try to do that.
I forgot to mention that she's an alumna from our So also she was a graduate in physics from Técnico, and also she did graduate work at the Faculdade de Ciências on the biomedical physics. Is that right? So
Yeah, that's right.
She has not been with us for 15 years, but she was one of us for several years. Yes. Thank you.
I'm actually one of you now again, because I'm doing the master's in data science, trying to at least. So,
okay, so you are a student.
Studying. I'm a student again as well. So thank you, Mario, for a very kind invitation to be here, and also a very interesting talk by Rafael that actually addressed a lot of the things that I'm going to talk about. So it made my life a lot easier now, and I hope I can still keep you interesting through the next 20 minutes. So as Mario said, I'm going to present a project that is financed by the Operational Program Lisbon 2020 and the FCT Foundation under the Carnegie Mellon University in Portugal program. This is a multidisciplinary project. The other team members are INESC, Ribeirã, Técnico, ISR, Carnegie Mellon University. So there are many researchers involved doing this, from doctors, medical doctors, to engineers, again, addressing the topic that Rafael addressed earlier of having a lot of people from different backgrounds working in multi-morbidity. And I totally agree, that's very helpful to have. I also like to thank my team mates for many of the slides that I'm going to show here today, in particular Bernard Neves, that I stole some from him without his knowledge. So thank you, Bernard. So when talking about healthcare, and particularly now, I think all of us are very focused on healthcare and what is the future of healthcare. And sometimes we kind of become a little bit upset and think maybe what's coming and what we already have here. Sometimes thinking about the future, the future is here. So even in the present, we're already seeing a lot of the challenges that healthcare poses. And we think, are these challenges, are these opportunities to evolve? And I really hope there are opportunities to evolve. But in fact, we have seen a lot of differences happening in demand of healthcare services, as Rafael also addressed in his talk, in aging, in the rise of multi-morbidity, and we've seen a version of this graph already before. But again, as we've seen, multi-morbidity increases with age, and as people are getting older, multi-morbidity is also increasing. So this problem poses many, these are complex patients to deal with, complex patients to treat, and expensive patients to treat. And in fact, if we look at the share of spending in healthcare for many countries, it has been growing a little bit, not enough, or maybe at least not in line with what the healthcare demand is begging for. And so we have a lot of healthcare systems that, in fact, at this point are kind of struggling to remain sustainable. And this is probably only going to get worse as people age and multi-morbidity increases. So we really need to think how to do healthcare in a different way, also because we know we have a shortage of people working in healthcare. So these are data from the European Commission for Europe, and in 2020 we already have a shortage of about 1 million people, healthcare professionals, and what the World Health Organization estimates is by 2030 we'll have 10 million health professionals that we won't have these, and so this will again cause a lot of problems. We already have a lot of diversity in the way these healthcare professionals are distributed across the world. So there are many places in the world that basically lack healthcare professionals, but this is just going to get worse. The problem is healthcare is very complex. So we need more people, yes, but that's not enough. We really need to change the way healthcare is done, also because of costs, but we have a lot of complexity. We have disease complexity. Diseases are very, very complex. We have a lot of diseases at the same time. We have new diseases, as we've seen, and some of them just kind of overwhelm the healthcare sector completely. We have diagnostic complexity that require a lot of protocols and algorithms and guidelines so people can kind of navigate through the system and understand what are the diagnostic tests that they need for each disease at a given time. We have treatment complexity, fortunately. So we have a lot of innovation happening in this sector. So we have a lot of new ways to treat disease. We have workflow complexity because we have more and more teams of very large teams of professionals in hospitals taking care of people. And so we need to manage these people and all of the process happening in a very efficient way. And this also results in, again, also a figure from NICE in very difficult pathways for diseases. So basically navigating in the hospitals, navigating in the healthcare sector with the disease, and even for professionals is more and more something that is extremely complex. And that's, again, why it's also becoming more and more expensive. Fortunately, we also have more information than before, particularly on people. So we are, all of us, complex systems. We have, and so we can measure a lot of different data from each individual, a healthy or diseased individual. As we've seen, there's a lot of biomarkers that we can start to use based on a lot of these layers of data that we can access. And moreover, and particularly in this century, we have a lot of social data. So we have a lot of data on how people behave, whether individually or in groups. And fortunately, this data can also be used to promote health. And so we can start using this data that mainly or oftentimes is collected using these powerful supercomputers that all of us nowadays have in our pockets, in our purses. And these supercomputers can, in fact, collect data that can help diagnose a lot of diseases that we have. And the hope is we can even start to diagnose these diseases early on. And so we can start to move towards precision medicine, something that people are already talking a lot about in the last 10 to 20 years. But putting all of this data that we're now starting to be able to measure together, we can really start to hopefully predict diseases earlier so that we can start treating them or attacking them earlier, and also then hopefully optimize the treatment of each person according to each specific constitution and reaction to the treatments. So that's where the Intelligent Care project arises. So this is, as I said, a multidisciplinary project where we want to kind of use a precision approach to multi-morbidity. Again, this graph, so basically what we want is to be able to treat people or to create a management system that will help in the first instance hospitals to treat people with multi-morbidity. Hopefully later on in maybe a follow-up project, we will also start working on the tools that can bring the patients also to be more empowered and or more able to deal with their own multi-morbidity. And so in this, to do this project, we kind of have a lot of hypotheses and a lot of knowledge now that supports why this is we are at the right time to do this. We now have the knowledge more and more that diseases are very much connected between each other. So we have clusters of diseases. We have, for instance, here the cluster of cancers all together, but then they also connect with a lot of other diseases. And the links are either genes or proteins, but so basically there are a lot of links. And so if the body starts having a disease, it's very likely that some other diseases will appear, and we can also start using this information maybe to anticipate certain diseases. Also, nowadays we kind of focus on the appearance of symptoms to start treating a disease, but again, and also using the knowledge from the slide before, we can be able, when we hopefully start to use more of the knowledge of other diseases and the evolution of these diseases to start diagnosing diseases before or even anticipating their course, so that again we can prolong our healthy lifetimes and kind of reduce that time where we're not healthy anymore after 65, because I'm also in the second stage of life and I really want to be healthier longer, as all of us for sure. Also starting to understand the relationships between the diseases, the different diseases and the symptoms, so that we'll be able to treat diseases correctly and have good outcomes. So And this is something that is also challenging because we tend more and more to go to specialists to treat for diseases. And in particular in Portugal, and this is not the same for the UK, we don't have a very good primary care service. So we tend to go to the specialist. And so the specialist will look at the disease that it's under his expertise and maybe not have such a system approach. And so, for instance, we can have heart failure, and the doctor will try to treat us for some symptoms that may be related to heart failure, as for instance, shortness of breath or fatigue, and the symptoms won't go away because maybe they're not caused by the heart failure, but by COPD or diabetes or renal failure. So we really need to take into consideration all of the diseases at the same time if we really want to alleviate symptoms and to really have patients' outcomes, clinical outcomes, and satisfaction as good as possible. But this again needs a tailored approach. So as we have more diseases, as we have more complex diseases together, we need to be able to treat these in a different way. So we cannot just say, we go to all the specialists and they all will give us medicine for each of the diseases individually, because that's when we start having 20 or 30 medications that we need to take every day. So we really need to start taking into account all of the interactions and everything that is happening. And we need to be able to, for each type of or cluster of chronic diseases, we need to be able to treat these people in the most efficient way, given their characteristics. And again, so this is where intelligent care starts. Intelligent care is basically starts from using artificial intelligence techniques to be able to describe first what we call these multi-morbidity phenotypes. So basically what we want to first see is what diseases typically come together and at what time, and what is the time evolution that we can expect of these diseases, so that we can early on start to treat the people for these diseases, and so provide the right care. Also in the right way. So we don't want to treat, as I said, everybody the same way. We don't want one size fits all. We really want to use an approach of patients like me. Basically, what we want is to really get to these personalized clinical pathways, so we're able to treat each person in the way this person needs to be treated. And we want to treat at the right time. So we want to be able to anticipate, again, knowing the temporal evolution, when these people will need to go to the hospital, so that when they will go to external consult and not to the ER. So we don't want these people decompensating and needing to have a more aggressive measures than otherwise if we were able to detect the evolution early on. So to do this, we are in fact at this point collecting hospital care, and we will also collect a lot of what we call these additional value variables. And so these are biomarkers or that we can collect using sensors and questionnaires, basically assessing this data, this individual data of each person, maybe not related to the diseases they have, but that will for sure influence the way their disease course happens. And so the hope is we put all of this together and we'll be able to create value for empowered patients. So as I said, in the first time, at this first stage, getting this management tool for hospitals to help them treat these patients, and probably a follow-up study, also be able to start what Rafael was also addressing, kind of give the tools to the patients to be able to themselves be more in charge of their diseases. So in this project, we'll first, as I said, collect a lot of data, and we're already doing this, and I'll show you some of the data that we're collecting. We need to anonymize all of this data because we want to do this in a very secure way. We know data privacy issues. We'll then do this clinical phenotyping, basically identify these clinical profiles of patients according to the diseases they have, get to the right way to treat these patients, get to the clinical pathways with a lot of granularity, basically trying to treat each patient according to his individuality, and then build this system that will be able to help manage these patients in hospitals setting. So as I said, the first step is collecting this large data set where we include structured and unstructured data. So basically we're getting all of these interactions of patients with hospitals, and we get all the data from their prescriptions, their evaluations, the results of exams. We're collecting not only the structured data, but also free text data. So, and this is because we know that this will for sure, it's difficult to treat, but it will for sure increase the accuracy of everything that we'll be doing. And then what we need to do is to be able to kind of look into this free text in a way that it's fast, and so we can also build this prototype to use in the future using data that is not classified. So basically we're building a tool that looks at tests, at text, at free text, and basically what it does is goes and understands what each of these words means, if it's a symptom, if it's a treatment, if it's what it is. Also understands the negative. So if we have without, it will understand that that doesn't mean that the person has the condition, but it does mean that the person does not have the condition. And so the goal is to have tools that will do this automatically and then be able to look retrospectively at the data that we are collecting now to build this tool, and also in the future to learn with the patients as they come along and keep getting a better and better results. And so while we're doing this, and while we're doing this, all of this data collection and kind of getting together all these tools that will help us look at the data and build these models, we also be looking at some available free data sources and start to test some of the tools that we are developing so that we can then proceed with the data that we are collecting. So one of the first studies that we did was look at the MIMIC database and start to understand if we could, using these text types, this ontology that we had before, and start to understand what the diagnostic of each of these free texts were. So in this case, we were looking at discharge notes, and what we were trying to do was to automatically understand what the patient had. And so we could really, with very, very good results, understand and classify the discharge notes according to the diagnostics, the many diagnostics that the people had. And so this is a very good proof of concept that we will also be able to do this with the tests that we'll have from our hospitals. Other study that we did was look at, again, a freely available database with Huntington disease patients and start to understand what is the time evolution of diseases. So this is kind of a difficult slide to read, but starting with patients with diabetes, understand what were the time evolution to get other diseases. And what we saw was that typically after a few years, these patients will develop, for instance, hypertension or dyslipidemia. And then what was the average course of all of the disease, all of the patients in this database. And so we could confirm there are many relationships between chronic conditions, for instance, hypertension, dyslipidemia, diabetes, heart failure, and could follow and establish what were the average time for appearance, not evolution, because the diseases probably were already there, but to have symptoms first start to appear. Another study that we did, trying to understand what is the risk of multimorbidity in hospitalization, and also kind of helping us in the predictive part of the tool. So basically, if given a certain cluster, a certain clinical phenotype, if we can start to predict how often people will have to go to the hospital, for instance, for an emergent episode, we start looking at the data for COVID, and what we saw is that people with COVID, again, we could kind of redo the multimorbidity curve. So we could see that patients with, as they get older, they'll also get more diseases. But most importantly, that as each chronic disease was added, the risk of the patient being hospitalized or going to requiring intensive care or dying had a very large risk. So as multimorbidity as a real risk for people to need to go to the hospital. It will have people have more serious disease and dying, unfortunately, more often than not. Lastly, what we're also doing is, at this point, kind of understanding how we can collect is what we call these additional variables of value, be it physiological biomarkers or cognitive variables or the social determinants of health. So either doing manual capture of these variables or automatic capture, either using wearable devices or other types of smart sensors. And so we know, and there's a lot of research on this, that these type of variables really help on either the management of these patients, and also, again, putting the patients more in control of their own health. This is all great. Artificial intelligence has a lot of promise. We know that a lot of this is really going to revolutionize healthcare. I'm totally sold on this. I really think that that's where the change is coming from, and that's what's going to make healthcare really be something completely different in a few years than what it is now. Unfortunately, what we have seen so far is that we can have an amazing tool that works extremely well in a controlled environment, but as we try to go and move to real life, many of these tools will fail. And so this is very often not so much a problem of the tool, not so much a problem of even the data set. Of course, we know that these tools will have to be adjusted to new populations, to new environments, but still the main problem oftentimes is that we did not really address how these tools would be integrated into hospital care. So that workflow thing that I talked before, that is very complex, if we don't know where the tools are mostly needed, and if we don't anticipate how professionals are going to use them, and if they are able to use them at the time that they need to use them, then they will fail. And so that's why at Hospital de Luz, we are creating a delivery process for all of these tools, again, using a multidisciplinary team that has from medical doctors, of course, to people in management, to engineers, to people specialists in usability, in human factors, that look at these problems from the start and understand how these tools can be built in a way that they really help, and that we can really make sure that we will deliver the value that they promise. And again, I'd just like to address the team that is still involved in this project, and open to questions. Thank you very much.
Thank you so much, Francisca, again. I also have to thank again Rafael, because he has been answering all the questions that we had on the backlog of this talk. I think we have one open question now, which is directed to Francisca. So I will let you answer live. It's from an anonymous attendee, I see, but it says, can you read it? Francisca, thank you for your presentation. My question is, how well connected are the IT systems of the different hospitals and primary care in Portugal to allow the share of information and interoperability, and therefore increase the level of care of the patient? In Portugal, we have a very good health record to support treatment patients, to really apply value-based healthcare, and to use, I don't know what the RW stands for, but I'm sure you know, to really assess results of new drugs, etc. So, and then there is a reference to regulation, GDPR, concerning the use of wearables, okay? So the conclusion is, do you think Portugal is ready for secondary use of data to improve the healthcare system? Okay, thank you, Anonymous, for the question. And
yeah, this is the question, right? And this is also why this is what I just presented is still a research project, and it's not reality. So of course there are many problems. I cannot speak about every hospital in Portugal. I know the hospitals where I work with, and yes, we have a lot of issues concerning interoperability and connection all of the different systems and databases. That, of course, is an issue. It's an issue in healthcare, is an issue in banking, is an issue in, I think, every sector of activity. So it's a difficult issue. It's also an expected issue because, of course, I don't think anyone expected that digital world will grow so fast and that we would have such big amounts of data to deal with. And so systems are also evolving. So yes, there will be a need to put everything together. I strongly believe that this will also happen kind of decentralizing all of this system development more to small startups or small companies that each of them will focus on a different system. We'll have a lot more cloud-based systems that will have to interact with each other, and we need to get basically data models that will be able to kind of connect all of this together. So it's a very complex topic that Mario, for instance, here would be much better equipped to answer than I would. But I would say that maybe we're not there yet. We would not be able to do this type of interoperability to get these tools, very complex tools, working for every hospital. But I think we can start, and I think we already can do some things also with value-based healthcare, also with real-world evidence data. So maybe we start small, aiming very high, and I think this is the time to start, of course, with a lot of difficulties, but I think we can do it. And GDPR, I think, yes, it poses some challenges, but I think that with the right tools and kind of taking that into account very early on in the project, we can also kind of start to understand how can we integrate the data privacy issues into all the tools that are built. So I don't think that will be such a big deal to, and I don't think that will hamper the what we need to do to be able to change healthcare. Hope I answered, or maybe I did not answer, but that's really because there's not really an answer at this point yet.
Okay, thank you. So I got an email from Rafael, but I see that he is back online. So I hope it is solved. I would like to know if there is any other question from the audience. Yes, there is one raised hand. Adriana Santos, please. Adriana, I think you can speak. You asked to talk. Okay. Maybe she can come later. I have another question here from Renato Mota. Are you ready to believe that real-life diseases classification is connected with the ICD-10?
That's a really interesting question, and it's basically we have these systems that provide us with hard outcomes for disease classifications, but we know that the level of ascertainment is not 100%. That is, not everyone with a condition will be classified as having ICD-10, and vice versa. Not everyone with an ICD-10 of a classification will really have the condition. So the usual, and that's a valid criticism, the usual approach that has been used for the type of work that we're doing is to try to triangulate also with medication. So if we find out the specific conditions and we know which medications patients with those conditions are likely to use, then there's through the records as well, the electronic health records, we can work out if those medications are being used for those individuals, and that way try to get to closer. I would definitely will not say that it's the perfect truth, but get closer to the truth as to whether they do have what the ICD-10 code is saying or not.
Okay. So I think we don't have more questions to answer. We also have reached the time. We are exactly on time to finish. So I think at this point, I would like to thank again the speakers for helping us. I think it was a wonderful evening because you opened so much perspective, and I'm really happy that you have been able to join and give like this view from the hospital, and Rafael focusing so much on the healthy living side of it, of the equation. So thank you both very much, and stay tuned for further announcements of the redeSAÚDE seminar. Hopefully in 2 months we will have another group of guests to bring another team for discussion. Thank you.
Thank you. Bye-bye.
Bye-bye.
Thank you.
Bye. Thank you.
Thank you.
Thank you.